We talk. We laugh. We sing. These are uniquely human ways to communicate.
The voice is really a pretty elegant, important function in human life, in societal interaction, in professional interaction, in family interaction.
When a voice is impaired or silenced, the physician who can repair it gets to be our hero.
Laryngology is really a special little part of medicine. It deals with some of the most human aspects of daily life. We're talking about how people communicate, how they talk.
It's the most amazing field. Actually, as I got into it, I was even surprised by what an impact voice has for people and how incredibly affected they are when their voice doesn't work, and how incredibly grateful they are when we can do something to make their voice work better.
The moon came out tonight in Montana.
Michael West's great love is singing, especially country music.
It put me in a mood, depending on what the song is, or brings back memories. I'm just into music and it'll never leave my bones.
Michael's ability to sing was threatened 3 years ago when he began to notice something just a little odd in his throat.
Felt like I had got a blackberry thorn in there or something, scratched my throat a little bit. Something, maybe I swallowed a bad kernel of popcorn and it scratched my throat a little bit. And this went on and it healed up, and then it went away and it healed up and came back again. Kept doing that.
Michael tried to ignore the problem for a year and a half before seeking medical attention. When he finally did call his doctor, a throat biopsy revealed laryngeal cancer.
There was no pain or no difficulty swallowing or talking or anything. And they come to find out it was squamous cell cancer on my epiglottis.
The epiglottis is a flap that separates our trachea, or windpipe, from our esophagus. It moves to allow us to either eat or breathe. Sound is generated in the larynx, often called the voice box. Vocal folds, also called vocal cords, are membranes stretched across the larynx. They vibrate when we talk or sing. Hoarseness, pain, or difficulty swallowing may indicate a problem that should be treated.
When the voice is rough after you yell or scream at a Husky game or a Seahawks game, okay, that's not great for you, but that'll probably go away in a day or two. But if it doesn't, especially if you've got other symptoms, if you're clearing your throat a lot, difficulty swallowing, maybe a little bit of shortness of breath with exertion, any of these start to get mixed together with hoarseness, there's something wrong with your larynx, and you should get an evaluation.
Michael was referred to Dr. Albert Merati, a member of the University of Washington Medical Center's Otolaryngology head and neck surgery team. His specialty is laryngology.
Laryngology is the part of otolaryngology, or ear, nose, and throat, that deals with disorders of the throat, which basically are breathing, talking, and swallowing.
Or in Michael's case, singing. Michael was worried about cancer, but he was terrified of losing his voice.
When I first met Mr. West, I'm pretty sure he had a bolo tie on, and he was kind enough to bring me a CD of his recordings. He had a laryngeal cancer. He had a cancer on his voice box. Here's a guy with a terrible medical problem, whose persona, whose interests and desires are related to using his voice box.
Hello.
Hello.
Hi there, Mr. West.
Dr. Merati's goal was to save Michael's vocal cords while removing the tumor. To do that, he offered Michael an endoscopic technique called transoral laser surgery.
So, I know you visited Dr. Merati.
In Michael's pre-op exam, resident physician Dr. Chu explains what will happen during surgery.
We will be placing a scope to get a look at your voice box. And we'll, through that, be able to use cameras to get an even closer look. And then we'll be using a CO2, carbon dioxide laser, to address removal of that lesion.
Transoral laser surgery, the minimally invasive approach to laryngeal cancer surgery, involves going down through the mouth when the patient is asleep and using a laser beam to cut through the healthy tissue around the tumor. and is really an exercise in 3D spatial orientation, because you're operating on a three-dimensional curved structure with a tumor in the middle of it through somebody's mouth under a microscope using a straight laser beam.
You want my hat off?
It'll make it easier for me to look around. I'll be shining a light towards myself. Okay.
Now I got hat hair.
You look fantastic. Okay.
Traditionally, surgeons have used an open procedure through the neck to remove laryngeal cancer, cutting into the voice box. Risks include damage to blood vessels and nerves that are vital for swallowing, breathing, and talking. But since the late 1990s, Dr. Merati says, the option of laser surgery through the mouth has caused a paradigm shift in treating laryngeal cancer.
People want their cancer treated, but people also want to save as much normal function as they can.
Dr. Merati assures me that he won't have to get close to the vocal cords and shouldn't have even any change in my voice, let alone lose it.
Relax your tongue and say, ah. Good. Okay.
Michael is looking forward to being healthy again after his surgery and to being free of the emotional burden that accompanies a diagnosis of cancer.
I find it very hard to think about anything else except this cancer. And that means thinking about myself and what am I going to do and how do I feel and what if I die and what do I do about this? And that's on your mind all the time to where you don't get anything else done. So that's mainly how my life's going to change, is I'll be able to concentrate on doing other things and things for other people.
Specialized technology plays a vital role in this procedure.
Getting the safest laryngoscope with the most light and the best handling of the tissue is key. You can't just put the same laryngoscope in every patient.
This scope is made specifically for tumor surgery. It's a little bit shorter because we're working on the upper part of the throat, but it's really designed with every little piece to safely get at all the nooks and crannies of the throat without injuring the tongue, the teeth, or any of the vital structures. Take a 0-degree telescope, please. What's our FI2, gentlemen?
1P1.
Okay, great.
First, Dr. Merati and his team map the tumor.
These are the vocal cords down there in the distance, and that's my instrument holding the voice box up. And right there is where it turns to irregular. That's a good shot of just the junction between the cancer and the normal tissue. The whitish irregular area, that's all tumor. So, okay, let's get moving.
Michael's tumor is about 3 centimeters by 1 centimeter.
All right. What's my laser setting?
4 watts, 0.1.1.
Okay. Laser on.
Ready?
As the team removes the tumor, they'll also take small samples around the edges in case the cancer has begun to spread.
Great. So here is the tumor. This is a straight cut right here, just to above where the vocal cords. The vocal cords would be about where I'm waving right here. Coming around the edges, it's all clear here. And we're checking all the edges to make sure there's no evidence of any cancer. First frozen, right anterior arytenoid.
Samples from the periphery of the tumor are checked by a pathologist who looks for hidden cancer cells. If those cells are revealed under the microscope, Dr. Merati will remove a larger area of tissue.
Right now we're in between the two major parts of Mr. West's cancer operation. He just had the upper part of his voice box removed, which had the cancer on it. Our main goal was to see if we could get it out through the mouth carefully without having to touch his vocal cords and to preserve as much voice and swallowing and breathing function as we can. So far it's really gone nicely.
The edges of Michael's tumor are clean, so the first part of his surgery is complete. In the final stage, the team removes lymph nodes from his neck as a precaution.
There's such a high likelihood of small bits of cancer hidden in the lymph nodes that we remove them.
As it turns out, Michael's cancer had spread to some of the lymph nodes in his neck. So although the nodes were removed, his surgery will be followed by radiation treatment. Dr. Merati says that although they'll continue to monitor him, Michael's prognosis is very good.
We didn't have to touch his vocal cords with surgery. We were able to get near them but not have to disturb them. He'll have some recovery time after radiation, but he should come through fine and be singing.
There are many conditions, many diseases that can affect an individual's voice or airway.
One aspect of laryngology, which is my particular interest, is neurolaryngology. Neurolaryngology deals with the neurologic aspects of the larynx. There are a number of diseases such as Parkinson's disease and another one called spasmodic dysphonia or laryngeal dystonia that affect the larynx and affect the function of the larynx. For example, in laryngeal dystonia, the vocal cords get incorrect signals from the brain and they don't function well. And sometimes it comes out with a very tight, strangled voice, and other times the vocal cords will open up in the middle of a sentence and the patient will have a very breathy sound.
In addition to treating patients, physicians at the University of Washington Medical Center are involved in ongoing research. Medical discoveries in the lab eventually lead to improved patient care in the clinic and operating room. Dr. Al Hillel's research in neurolaryngology complements his treatment of patients with laryngeal dystonia.
My research has been in neurolaryngology and in particular electromyography. When muscles move, they give off an electrical signal, and if you record those electrical signals, you can then get some information about the nerve. And one key focus has been to record all the laryngeal muscles at one time and correlate with the voice which muscles are more responsible for creating the voice disturbance in laryngeal dystonia, and therefore targeting the treatment based on those findings.
Sometimes the problem is simply the passage of time. Aging affects the entire body, and at 94, Anna Butler was having a hard time being heard.
Having been a school teacher, I had a voice that would carry for blocks. And then it got very hoarse, and it was difficult for me to speak.
At 94, parts of her body weren't working as well as maybe they were when she was 24. But her brain was working, and she had lots to say, but was having a hard time saying them.
Anna couldn't speak loudly enough to contribute during her book club meetings.
I couldn't really speak up the length of the table to give my views on anything and have the words come through with any clarity.
When she spoke, she was leaking a little bit of air. She had a breathy sound. She was pushing. She was forcing the sounds out because the vocal cords weren't as resilient as they used to be.
A procedure offered at the University of Washington Medical Center's Otolaryngology Head and Neck Surgery Center involves injecting the vocal cords with a bulking agent such as collagen. Anna's treatment took only a few minutes and was performed under local anesthesia.
There was just one prick in my throat. That was all there was to it. Then I had to keep quiet. I couldn't talk for a day or two. And afterwards, it was quite a revelation. I was so much better.
The vocal cord injections typically last 4 to 6 months. There are different materials that can be used, some which don't last as long, some which last longer, and it depends on each individual patient's situation and their needs. We cater the injections to their needs and their medical situation.
Anna had originally seen a cardiologist for shortness of breath, who realized her problem was in her throat and referred her to laryngology. Collaboration between physicians and specialties at the University of Washington Medical Center enhances patient care.
In the Division of Laryngology, we work with the pulmonary department because many patients have pulmonary disease, and it's always a question of whether the problem is in the trachea or lungs or if it's in the larynx. We work with thoracic surgery because, again, a number of issues are right on the borderline between the trachea and the larynx. We work with the GI people very closely, both GI medicine and GI surgery, because gastric reflux can affect the larynx a great deal. And so we collaborate with them on a number of studies.
Optimal patient care is the goal of research and collaboration, as it is in everyday practice. Patients are at the center of everything the team does.
My overall philosophy in dealing with patients is primarily to try to listen to them. By the time patients get here, they often have gone through a number of other medical evaluations, and often they have fairly complicated disorders.
Right this way.
Carol Smetheram is one of those patients. When she first saw Dr. Hillel, she'd already been through 9 years of breathing problems.
Initially, I lost my hearing. That was my first symptom. From there, it was just bloody noses. My gums were swollen and sores. You could actually see the sores on my gums. And then my breathing. I was 17 years old. It was a week before my senior year in high school. And I really had no idea what was going on. All right, Spider-Man.
That was in 1989. Carol was diagnosed with Wegener's granulomatosis, a disorder that restricts blood flow and can damage vital organs. Treatment at Seattle Children's eliminated most of her symptoms, but not her breathing issues.
My symptoms pretty much stabilized. My hearing, I wear hearing aids, bilateral hearing aids, and no other symptom has come back except for the tracheal stenosis.
Tracheal stenosis is a narrowing or constriction of the windpipe, and it was the cause of Carol's breathing difficulty. She was referred to Dr. Hillel for this condition in 1998.
As we look at a picture of Carol's larynx, this should be wide open because this is the opening to her windpipe. Instead, you can see she has a very small hole, and she had been breathing through that small hole for quite a while, and of course it restricted her activities.
Dr. Hillel and Carol discussed treatment options, including a surgical procedure called tracheal resection.
As I explained to the patients, it's like having a garden hose that has a bad segment, and if you just cut out the bad segment and put the two ends together, then you can repair it.
Initially, Carol opted for a conservative surgical treatment, including dilation of her trachea to stretch the opening. Each dilation procedure was effective for 5 or 6 months, but when it wore off, Carol couldn't breathe well enough for even the least strenuous activities. Over time, dilation was effective for shorter periods, and Carol began to seriously consider another type of surgery.
I've just been putting it off. Just kind of scary. And my 2 kids and not being able to lift and do a lot of things for a long time made me postpone it. Finally got to the point where the last dilation, after a month, it was narrow again. And so I just thought, enough is enough. And I had to get it done.
Ethan, you want a drink?
Carol's surgery would be a little more complicated than normal due to the location of her tracheal stenosis.
In Carol's case, her narrowing involved not only a portion of the trachea, which is its lower part, but also involved this bone, this cartilage called the cricoid cartilage. The cricoid bone is one of the key bones in the larynx. As we follow it around, as I turn this model over to the back side, we can see that this cricoid bone is actually very large. These small bones sit on top of the cricoid, and as you'll be able to see, when these bones move, the vocal cords move. So the cricoid bone is absolutely critical to the function of the larynx. And so resecting part of the cricoid cartilage in the front made Carol's case more complicated. So not only do we have to take out this part of the trachea, we had to take out this part of the cricoid and then bring her trachea up and reconstruct the cricoid. Okay, as usual.
And now Carol is returning for her 6-week post-surgical follow-up. An endoscopic exam allows Dr. Hillel and speech-language pathologist Pat Waugh to check Carol's vocal cords in action.
Okay, now take a nice breath in and gently say E for about 10 seconds. E. Okay, good. And then count out loud from 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Good job.
The examination shows that Carol's recovery is progressing nicely.
This area right here is where we did the repair, where we sewed the larynx to the trachea below, and you can see it's nice and open, and it's much more open than it was at any time since surgery. It looks very, very good. So that's, that's good. That's good.
Our voices express not just words, but moods and feelings as well. The tone of a voice enhances our understanding of each other.
There's this saying, that the eyes are the window to the soul, but you can be on the phone with your friend and in 2 words tell how they're doing, regardless of what they're saying, just by the tone of their voice. As the voice fades or becomes hoarse, it affects how people perceive themselves, how other people perceive them.
Hey.
Stephanie Toller, a business student who runs her own cleaning service, started losing her voice last year.
I had to give a speech actually for one of my classes. It was a sales class, and I had to do a sales pitch. And my voice started going, and I started kind of worrying about my sales pitch, so I stopped talking for a couple of days, and it got a little bit better, and I made it through. But then it slowly started to degrade again, and I thought, well, I'm just sick. I have a bug, no big deal. So I didn't really deal with it, and it would kind of come back a little bit. And then it started getting worse and worse, as in my voice would start cutting out. Or if I would go out with my friends and I was in a loud environment and I had to raise my voice to talk to them, the next day my voice would be completely gone.
Stephanie had a vocal fold lesion, a growth on her left vocal cord that was most likely caused by a small blood vessel that broke and bled.
When we found the growth on her vocal cord, it wasn't just, okay, you've got a growth on your vocal cord, let's go operate on it. That does not work. The right way to treat these problems is to see what effect this little 2 to 3 millimeter bump is having on the patient. What are the causes for it? What are the things we can do to control it? Is there vocal overuse? Are there patterns in her vocal use that make her more likely to develop it? What's the point of removing it if it's just going to come back?
Answering those questions requires a team approach. Stephanie worked with Dr. Merati and speech-language pathologist Ginger Hamilton at the University of Washington Medical Center's Otolaryngology Head and Neck Surgery Center.
We share in the gathering of the history and trying to understand what the patient's complaints are and concerns.
Sometimes we're asking similar questions, but we're listening for different answers. And we put our thoughts together with the patient and try to get at the heart of the problem. And we'll come to a treatment plan based on our discussions in a very open manner.
For Stephanie, the first step was to try steroids and several days of resting her voice. It wasn't an easy week for her.
In the business school, you have very regular presentations that you have to give. And there were a few presentations that I had to give while I was on voice rest. That was my assigned date. I was working with a group. And so we tried to do some funny things to kind of compensate for the fact that I wasn't able to speak. But the fact is, it was difficult to be in group meetings to talk about what our plan was going to be. You know, I had to IM and have somebody else speak for me.
And your surgery's coming up soon.
It was determined that surgery would be the best option to remove the growth. But first, Stephanie had some preparation with Ginger Hamilton.
And what about vocal hygiene over the past week?
I've been trying.
Okay.
I really have been trying. It's difficult.
She has been straining and misusing her larynx as she's speaking. And so my goal is to help her unlearn those behaviors so that she can then move on to healthy voice production, and especially then not have a recurrence of this lesion. Without intervention, it's very easy for these types of lesions to recur. Let's practice a few exercises right now, just working on trying to get the best sound that we can with the least amount of effort. See if you can feel a little tickle in your lips.
Okay.
Okay, good. Any tickle?
A little tickle.
A tiny bit? Okay.
Tiny.
The goal of the exercises is to improve Stephanie's vocal hygiene, both before and after surgery.
Vocal hygiene is a term that indicates we're interested in a person using their voice in the healthiest way that they can. And so we're talking about a clean sound, if that's possible, with the least amount of effort, and certainly no abusive or misused behaviors. A lot of throat clearing and coughing would be the opposite of vocal hygiene. A lot of vocal strain would be the opposite of vocal hygiene. Other things with vocal hygiene, you've been drinking plenty of water?
Yeah.
Ginger Hamilton also addresses issues such as hydration and diet.
Working all of those pieces together to help the patient have the best, healthiest larynx possible.
Getting Stephanie ready was a team effort, number one person in that being Stephanie. And she did a good job. She got herself ready, she controlled her voice use, she took the medications we prescribed, worked with the voice team. That's the recipe for success. That's a growth dead ahead on the left.
Stephanie is having a micro-direct laryngoscopy, which means that Dr. Merati will use a microscope to look directly at her voice box during surgery. Preparation, including choice of equipment, is critical to success. The powerful microscope offers Dr. Merati a clear binocular view of the mass in Stephanie's throat. The quality of this image makes it possible for him to operate in a very constricted and delicate area.
There's very little room for error. The distance between the surface of the vocal cord and the vibrating part of the vocal fold, the reed, the thing that makes the sound in the vocal cord, is less than 1 millimeter. And we have to operate in that 1 millimeter layer without damaging the other structure.
Our laser on.
The team uses a laser to control blood vessels during surgery. It's important to minimize blood in the area so that Dr. Merati can see clearly.
Can I have the micro scissor to the right?
He uses a specially made microsurgical knife and micro scissors to open the vocal cord and remove the growth. This procedure is so precise and the knife is so delicate that it will be used only once and then thrown away after Stephanie's surgery.
Here's a specimen. I just want to show our guys just how small of a lesion it is that will affect somebody's life.
After surgery, Stephanie rested her voice for a couple of weeks and ate a very bland diet to protect her throat. She worked with her speech therapist to begin using her vocal cords safely again, and she'll continue to work on vocal hygiene. And she's back in full communication with her clients, her employees, and her classmates.
I feel great. Yeah, I'm excited to have my voice back. You know, this was my God-given voice, and I didn't have it for an entire year. So to get my voice, you know, pre-voice invasion of a year back is really exciting for me.
Perhaps you will see stars.
Our voices, so essential to human communication, so much an expression of who we are, and so important to protect.
And your sweet love.
For more information, to make an appointment, or to refer a patient, contact University of Washington Medical Center, Otolaryngology Head and Neck Surgery at 206-598-SING, or go to www.uwent-headneck.org.